Welcome to the AOA podcast series on Lessons in Leadership. My name is Ann Van Heest, and I'm honored to serve as the 2023-2024 AOA President. As we discussed in our August 25th podcast, part of my AOA presidential duties includes joining the Orthopaedic Carousel. These are presidents from 5 English-speaking countries, and we attend each of each other's annual meetings. The AOA is a leadership organization. As we discuss lessons in leadership, we can learn so much from the leaders of other countries. The diversity of our profession includes the diversity of orthopedic surgeries in other countries of the world to compare and contrast to our own. One of the meetings that I am excited to have attended is the South African Orthopaedic Association meeting in Cape Town, South Africa, from September 4th to September 6th. I am pleased and honored to host the SAOA 2023 President, Dr. Basil Vrettos, in our podcast today to discuss lessons in leadership from his vantage point. Thanks, Basil, for joining me today for this conversation. So, Basil, can you start first by telling us a little bit about the SAOA and the meeting that you just held?
So the SAOA was started in 1942, and it really was after a donation from Nuffield, Richard William Morris from the UK, and that was to fund the orthopedics in South Africa. That was the beginning of the SAOA, but it was called the Orthopaedic Surgeons Group, and then in 1951 it became the Orthopaedic Association of South Africa. It was the following year that we joined the sister societies, and we received the Jewel of Office from the Queen Mother at the second COMOC meeting in the UK.
And tell me a little bit about the SAOA itself. How big is your organization, and what are the offerings that you have for your members?
So we have about 850 full members, and the association really looks after both the public and private sector. We have a public and private sector committee, and we deal with a lot of insurance issues, any problems in the government sector, and we sort of represent them in any dealings they have with the health authorities or even government. We do a lot of education, so we do a lot of training programs. We also look after our subgroups, and we support the subgroups who, though many of them are separate, they still fall under our umbrella, and we support their meetings and they support our meeting.
So tell me a little bit by subgroups. You mean, would that be the subspecialties?
Yes. So like I'm part of the Shoulder and Elbow Society, so we fall under the umbrella of the Orthopaedic Association, though we do run our own meetings at times, but we always support the local meetings. So every year we will have a session or a day, and that will more be for the generalist orthopedic surgeons, because we have a lot of generalists maybe compared to the United States, because we have doctors working in areas where they have to be able to deal with everything. And so our meeting is aimed at the generalist, with the subgroups participating and educating them.
Yeah, that's one of the issues that we've seen as we travel across the world, is that relationship between the subspecialties and the generalists. So what I hear you saying is that most of the orthopedic surgeons in South Africa are generalists. Do you have an idea of how many of your registrars consider themselves generalists versus a specialist?
If you look at the main centers, so the super specialization will really only be in the main centers. And there will be a lot of people who are generalists, but they have a special interest. But they will still definitely still do general trauma. But also, in Johannesburg, Cape Town, and Durban, which are the major centers, you will have super specialists. In the smaller centers, you don't really have super specialists. Someone will have an interest in a subspecialty. So we have to look after them. But what we tend to find in the major centers, patients will choose their specialist. Certainly in the private sector. So they will choose a super specialist. Because in the smaller centers, they will go to who is available.
Well, good. Well, let's talk next about leadership. So the AOA is a leadership organization, and I'm interested in your journey to becoming president of the SAOA. Can you tell us a little bit about your journey and any tips that you might have for our young leaders?
Yeah, I think my journey was, I was often at the right place at the right time. And it wasn't that I think I was a bit of a reluctant leader. But anyway, probably what really set me off is when I did a fellowship in the UK in 1997. And the only reason I applied, I was doing shoulder and elbow surgery at the university, but I hadn't done a fellowship. And my colleague who worked beside me, he went and did a fellowship in Oxford in spine. So I thought, well, maybe I must do the same thing. So I applied to the UK and got a fellowship in Nottingham in shoulder and elbow surgery. And that was really a pinnacle part of my career, because unbeknownst to me at the time is that the person I did the fellowship with was one of the founding members of the British Elbow and Shoulder Society. And so through him I met the others, and then together his name was Angus Wallace, and his good friend, and one of the other founding members, Steve Copeland, became very close. And they really put me on a path and supported me. And I think soon after that, I went on the ABC Fellowship. And then the third thing was that in 2001, so the ABC Fellowship was 1998, 2001, I was the scientific chairman of the international meeting, the International Congress of Shoulder and Elbow Surgery, which was held in Cape Town. And so we got delegates from all over the world. And that was the start of the explosion of our shoulder society, because after that our shoulder society really boomed. And soon after that I became secretary, and then I became the president of the shoulder society. And then after that, it was actually, I think, at COMOC in 2016, the president then of the South African Orthopaedic Association asked me if I would be president, would I stand to be president? And I said it's the last thing from my mind. I said, I don't want to do it. I said, I've been enough. Anyway, but... and then
so it sounds like mentorship has been a really important thing for you.
Yeah,
like you weren't out there choosing leadership, but you had some mentors that chose it for you.
In a way, exactly. And particularly Angus and Steve Copeland. And then, of course, there was that older gentleman that taught me how to do elbow surgery that was at our meeting, Rael Jaffe.
Yeah.
He was really, he was a true mentor. Well, they were all true mentors. But it taught me the importance of mentorship, which I think we've lost a bit.
So what advice would you have about finding a mentor or being a mentee or being a mentor? Like, what's been important for you in mentorship relationships?
I think it's a two-way street, because you learn in a mentor just being a supporter of that person and giving them advice, and it's not about training them. It's about all the other things, because the training, you can train anyone to do an operation. It's how you approach your profession, but maybe approaching life as well. Because, in fact, I think that's probably one of the most important things. But you also learn from your mentor, so reverse mentorship.
Yeah.
Which I learned a lot, especially these days, from the younger guys, because they showed me how to use the computer.
Yeah. And I think at that time, shoulder and elbow was a fairly uncommon subspecialty. Is that correct?
Correct. Yeah. And it's really.
So you really kind of got in on the front of the wave of that being a subspecialty.
That's right. So it was in the late 80s, early 90s, and it was when shoulder arthroscopy first started. And it was I can't remember in the States, Steve Snyder and a couple of others from America who started it, and then of course it got spread around the world. But when I started in the later 90s, it was really starting to gain traction.
Well, it sounds like the choices you made and what you might say is serendipity, but really meeting the right people is what helped you on your leadership path. Yeah. Even if it's by chance.
But when I finally, when I turned down to stand for the Orthopaedic Association, then in 2020, two previous presidents phoned me. So I decided to speak to my wife, Lynn, because she often gives good advice. She's one of the sort of wise counsel. And she said, okay, she'll think about it. She said she thought and prayed about it, and she came back to me and she said, I think it's time you gave back. And she was quite right, because I think I had received so much from the orthopaedic community in the country and from the Orthopaedic Association, supporting me maybe in ways that I didn't realize at the time. And so then I decided, yes, I would stay.
Yeah, that's a really great concept, that part of leadership is really taking time to give back. And it's a really great opportunity to be able to do that for our profession.
Yeah.
So one of the other things that AOA is committed to is identifying and discussing critical issues in orthopedic surgery.
Yeah.
So what do you see as the critical issues facing the SAOA at this time?
So we've got both problems in the public and the private sector, and because of economics, in the public sector there's major funding cuts. So there's a moratorium on new posts, and if people leave posts at the moment, those posts will be frozen. And like many health systems in the world, there are too many patients for the number of surgeons, and certainly in our situation. And so that's the major thing in government. We've also had supply issues, so it's more due to maladministration, is implants for the government hospitals in certain centres, that those supply chains stopped. So the implants were not getting to the hospital because the local government was not paying. And
was this part of the pandemic, or was this more of a political issue?
This is more to do with maladministration, perhaps some corruption as well. But that seems to improve, and that was, in fact, the SAOA was the one who discussed with government and got that, and it has improved, but it's still a problem. I think in the private sector we have this this concept of universal healthcare that the government is promoting, which is a wonderful concept because it will try and even out the disparity between private and public medicine, because you have sort of 80% or 75% of doctors servicing 15 to 20% of the population in the private sector, and 25% servicing
75 or 80% of the public sector.
So there's this disparity. So they're trying to marry the systems, and I think one of the big issues at the moment is that they have just passed in government, or preliminary anyway, the National Health Insurance, which would be a funding model to achieve this. And there's a lot of concern that previous or money going into the coffers may not go to the right places. Anyway, it's still in its infancy, but it's quite a big concern for everyone at the moment.
During your time as a president, were there any critical issue areas that arose or that you concentrated on?
One is litigation. So we have had increase in litigation, which is certainly not like the United States, but it has been increasing, and largely because lawyers previously used to earn quite a lot from what we call the Road Accident Fund, which was a fund that when people had car accidents, and lawyers would earn from that, and they capped the amount lawyers could earn. And so they focused their attention on doctors who are well insured. And so there has been, that's been a bit of an issue, and so we have had to embark on an education program to the youngsters, particularly the younger surgeons coming in, to protect themselves, or just to be cautious and practice in a manner that will hopefully prevent them being...
That would hold up in court.
Yes.
And tell me a little bit about the Road Accident Fund.
So this is a fund that with every vehicle that when we buy fuel, that a percentage goes to the Road Accident Fund. And so it's a very large fund, a managed fund, and so that will pay for a patient who's involved in a motor vehicle accident, that will pay for their care, and will pay for their care in the private sector.
Is the majority of the trauma care that you provide through motor vehicle accidents, or what is the profile for trauma in your country?
So the biggest profile for trauma is pedestrian accidents.
Car versus pedestrian.
So we have that's our largest.
And would that be covered by this fund?
Yes, it is.
And do you have funds for covering work-related injuries?
Yes, so we have workman's compensation. And that also those patients are serviced or looked after in the private sector as well. There have been issues from time to time with how the process works, and sometimes it can be quite delayed. But and the Road Accident Fund is working, well, not all the time, but they have a system that if you have a patient with a road accident and you contact them, or they will contact you and say, okay, we've got this patient, want treated, particularly if it's the consequences of their trauma, and then they will pay for the hospital and everyone up front. But it doesn't happen that often. So there are problems in the system, but they do function.
One of the things that we've been hearing a lot about as we have traveled together to the different carousel meetings is physician well-being and physician satisfaction. Do you think that your membership has significant issues with that, or what do you think the general state of health is for a South African orthopedic surgeon?
Certainly, I think we have quite a good balance. Especially the younger surgeons, they have a much better attitude than perhaps my generation did. So they practice much better life balance, family and work. So I don't think we have such an issue as there might be in other countries. For sure.
And are there restrictions on working and work hours? No. And the other issue that we've seen as we've traveled across to the carousel countries has been diversity.
Yes.
So tell us a little bit about the diversity issues, both gender as well as race, ethnicity issues in South Africa, and what's unique in your country.
So of course we had apartheid, which I mean the worst thing, it was a terrible system altogether, but it was the education. So the black population was given an inferior education purposefully. It was called Bantu education. And because of that, you have a whole sector of the population, and they were really trained to be workers, even if they were intelligent. So very few blacks from the apartheid days gained an education, like became doctors or became lawyers. Mandela was different. He became a lawyer. That was unusual. So we are very backward in that sense in diversity. However, over the last, we've now been independent, well, not independent, we've had liberation since 1994, so it's nearly 30 years now. So we now have lots of young, well-educated black youngsters coming up. And so now, in fact, at one time, if you were black, you would get the job automatically, but now there's enough people of quality that get in on merit, a bit like our sports teams, which have become like that. But also women. I mean, I think we are now 20% of our registrars are women, so we've come a long way. Actually, I think. I'm not sure how it is in other countries, but we are improving all the time. And it's interesting because I travel up into Africa. The number of women in surgery is quite high and increasing all the time. It was really nice to see.
I did have the privilege of being able to attend the South African Female Orthopaedic Surgery Association while I was at your annual meeting. And this was their third year of having a meeting together. Yeah. So it certainly seems that gender diversity has become higher on the priority. Yeah. Just to get back a little bit to the racial and ethnicity diversity, since that was such a divisive issue in South Africa for so many years. Can you tell us just a little bit about how reparations worked and then where it's at 30 years later?
So I have to admit that I never lived in apartheid South Africa. I only came to South Africa when it changed. Okay. I did travel there, but I think the reparations are probably, there was a Truth and Reconciliation Council, which Desmond Tutu ran, and this was so that there could be forgiveness in that, and that addressed a lot of issues, but it never addressed the economic disparity, and that still exists in part today. So, but it is changing slowly. But it's all about education, and I think one of the biggest problems when things changed is that maybe enough emphasis was not put into education, particularly of the primary school education. So, people will say the education hasn't changed that much. It has changed, there's no doubt, but there are still issues.
So let's talk next about training the next generation now that we're talking about education. So our AOA membership includes many leaders that are committed to educating competent orthopedic surgeons. And we're just rolling out a competency-based education across the United States. Can you just tell us a little bit about the orthopedic surgery training in South Africa and whether you have experience with competency-based medical education?
So, and you presented this on at our meeting, and I think our system's quite different in the sense that it's getting onto the training program is extremely difficult, and any prospective trainee has to do at least 2 years as a medical officer.
So tell us a little bit, after you finish high school, you go straight into medical school?
Yes, so you do medical school for 6 years.
And that's part of your university training?
That's your university training, and then after that you do 2 years of housemanship or internship, and then another year of community service. So the earliest you'll get into a training program as a not as a registrar, then you would have to do, the earliest is then you could start orthopedics as an SMO then. But even those jobs are becoming difficult to get. So then you do another 2 years. So before you start orthopedic training, from the time of finishing finishing your school, it's probably 11 years. 6, 3, and 2.
So 6 years of medical school, 3 to 5 years as a medical officer?
No, so 2 years as houseman, 1 as community service, and then 2 years as a medical officer.
As a medical officer. And then you start your training program.
You start your training,
And how long is your training program?
So it's 4 years.
It's 4 years. And would that include fellowship training or subspecialty training, or is that only general orthopedics?
That's general orthopedics, and then after that, it would be your choice to do a fellowship.
What's the age at which most people finish their orthopedic surgery training in the South African system?
Well, I think I finished at 35, but so when I finished my housemanship, I didn't have to do community service in those days. I did 2 or 3 years of others. I did anesthetics, and so we tended to do a bit of general stuff before we chose our specialty. So that delayed it. But in my time, I didn't have to do a medical officer job. That's changed only in the last, I'm not sure how many years. But now you're looking at, so if you're 18, 11 years, you're now 29. You're going to finish your training in your mid-30s.
Yeah. And it sounds like one of the issues as well with the budget cuts that you were describing under critical issues is that there aren't as many residency spots available, or there might not be, depending on what the funding is at each center.
So that hasn't affected residence posts or registrar's posts at this time, but I suspect it may affect it in the future. The hope is that if things improve economically, that moratorium on positions or jobs will be lifted, and so there will be places available.
So it sounds like the training in South Africa is considerably longer than the training that we have in the United States.
Yes.
Do you feel like individuals finishing in the South African education system are competent? And are there ways that you evaluate that?
You mean as the trainees?
The trainees, yeah.
So I think when they do their medical officer jobs, they're working under people who are attached to the university. So they do get assessed prior to getting onto the surgical training. So you have to be competent, and they often get a lot of experience because there's a lot of pathology. So by the time they get on the training, they're well versed in surgery. In fact, one of my fellow consultants said he's got 2 junior registrars, and he says they're like consultants. He says they know everything and they can do any operation. Yeah. So he says it's very impressive. So some of them end up spending more than 2 years. So by the time, I would say our training, I think that's why we are often accepted into other countries so easily. Because by the time they finish, if you go, certainly the UK, there's so many South African orthopedic surgeons. of my generation. And that's, I think, because they have had it, they're very competent by the time they finish their residency, the registrar's job.
Yeah. And your predecessor, Dr. Dunn, was telling me a little bit about the work-based assessments that are done, and now that they're requiring some specific procedures that those be assessed and make sure that everybody, as they go through their training, gets assessed on that as well. It sounds like it is a very competitive specialty. Why do you think orthopedics is so competitive at so many different countries around the world? At some point in their system, that it's difficult to gain access to orthopedic surgery training?
I have to say it because it's fun. That's the one. It's the most. It's so enjoyable, and it's probably one of the most rewarding specialties because you have a problem that you sort out, and patients in general get better. Okay, not everyone does well, but in general, I mean, I think hip replacement is the most successful operation out of all operations, or almost.
Yeah.
So I think it's very fulfilling in that sense.
What's your favorite operation?
I don't really have a favorite one. I do a lot of shoulder replacements because as I'm getting older, I tend to attract the older patients, which I'm quite happy about because they're often the most easy to please in a way. Yeah, so I would probably say my replacements.
Yeah. Well, certainly, as you mentioned, joint replacements, whether it's hips, knees, shoulder, can be incredibly satisfying because of the pain relief and function that's restored. So I think we have that in common for all the countries that we visit. Well, thank you, Basil, for joining me today for this conversation. I think your leadership journey and your experience at the SAOA can really help broaden the mindset of our AOA members and allows greater appreciation of the diversity of orthopedic surgery across the world. It's been my privilege spending time with you discussing these important issues. So thanks again.
Thank you so much, Anne. Thank you.